So good morning everyone. Today we have a big subject about vascular ultrasound. We'll continue on the fundamentals of diagnostic radiology book club with your colleague Dr. Sabah. May he start?
Good morning everyone. Today's topic is about vascular ultrasound. Spectral Doppler ultrasound and color flow. Imaging supplement grayscale ultrasound by identifying blood vessels, confirming the presence of blood flow, determining flow direction, detecting vessel stenosis, occlusion, assessing the perfusion of organ and tumors, and characterization of blood flow dynamics to detect physiological abnormality. We should know something about the basics of the Doppler ultrasound. First thing is Doppler effect, refer to the change in the frequency of the sound wave that occurs due to motion of the sound source, a sound reflector or a sound receiver. In medical diagnosis, the Doppler effect is used to confirm blood flow by detecting the change in frequency of the ultrasound wave that occurs when sound is reflected from moving clumps of RBC. The reflected sound frequency increases when the blood flow direction is toward the Doppler signal, and it decreases when the flow is away from the Doppler signal. You have Doppler shift, a change in the frequency between the ultrasound waves emitted by transducer and the ultrasound waves returning to the transducer after reflection from the moving RBC. The shift in sound frequency results from a Doppler effect. Increase in frequency is termed as positive Doppler shift. The sound waves are compressed by encountering RBCs moving toward the sound source. Decrease in frequency is termed negative Doppler shift, as the reflected sound waves are stretched by RBC moving away from the sound source. The presence of the Doppler shift within a blood vessel confirms the presence of blood flow. We have Doppler equation to understand the Doppler shift frequency. We have Doppler shift frequency equal to frequency of the sound reflected and the frequency transmitted. The other one is equal to 2 by velocity of the blood flow velocity over the cosine of the Doppler angle over the constant speed of sound in the tissue. It's 1540 meters per second. This is something theoretical about how we measure the Doppler frequency shift. From this equation, we know that the frequency shift is proportional to the velocity of the moving RBC, the frequency of the transmitted Doppler ultrasound beam, the cosine of the angle between the incident Doppler ultrasound beam and the direction of the blood flow. The angle is called the Doppler angle. The largest frequency shift occurs when the largest Doppler signal will be obtained when the Doppler angle is 0. The cosine of 0 is 1, and no Doppler shift will be seen when the Doppler ultrasound beam is directed perpendicular to the blood flow. It means that the angle is 90, the cosine of 90 is 0, so in 90 there will be no flow.
When you are perpendicular immediately to the direction of the blood flow, you'll have zero Doppler.
Zero Doppler.
Nothing. Okay? While you are directly in the face of the blood flow, zero angle, okay, you'll have the maximum shift. However, usually it is impossible to be in the blood flow because you should be in the vessel, which is impossible.
We're usually trying to be always less than 60 degrees.
So we try to do the angle less than 60
degrees, yes. This is the picture of the Doppler frequency shift. We have the transmitted sound wave and the received sound wave. And we have a moving RBCs, and the sound wave is transmitted from the ultrasound probe. We have moving structure and return it back. When the frequency of reflector is more than the frequency of the transmitted wave, you have a positive Doppler shift. If opposite, the transmitted is more than the reflected, you have negative Doppler shift. The RBC motions causes an increase in frequency of the retinal echo due to Doppler effect. This is the basics of the Doppler effect. Doppler angle. This is the ultrasound beam coming on the vessel, and this area is the Doppler sample. The place we take from the vessel should be in the center, and this is the flow of the RBC. This angle we try always to be less than 60 to have a good frequency shift. This is about the equation and the cosines. The less is the better. So here in the 90 degree we have no Doppler shift, so you will see nothing. In 0 is the best one, equal to 1. This is the scale of the Doppler. The vertical scale we have here is the blood flow velocity in meters here, and the horizontal is the time in second. The image to Doppler spectrum of the common carotid artery. This is the velocity, and this is the time. We have peak systolic velocity, diastolic, and we count it in meters per second. Because the velocity and Doppler frequency shift are directly related mathematically, Doppler frequency shift may alternate because maybe alternatively we use it on the vertical scale without changing the appearance of the Doppler spectrum. Flow towards the Doppler beam, positive frequency shift, is displayed above the baseline, and flow away from the Doppler beam, usually negative Doppler shift, is placed below the baseline. In Doppler we have a spectral display. Either we have high resistance flow or low resistance flow. In the high resistance flow we have triphasic, early diastole and the early systole. In the early diastole we have flow reversal, and the late diastole, a small peak, also seen. This is high resistance.
This pattern called high resistance pattern. The one
Yes,
on the left
triphasic.
side.
We have three phase.
You have zero flow in the diastole at the
In
late
the
diastole,
yes.
and rapid acceleration in the systole, rapid going to the peak. This indicates the vessel is a high resistant flow vessel. That means it supplies organs that are not vital, like upper or lower limbs, not like the brain, for example.
Non-vital.
While on the left side you have the
Low resistance.
low resistance pattern.
Even during the diastole we have blood
Flow
flow.
is continuous. Even in the diastole there is a flow. It does not reach the zero level.
No
This
zero.
indicates low resistance flow pattern. It supplies vital organ like brain or kidney or things like that.
High resistance patterns seen the artery supplying the skeletal muscle like iliac, femoral, popliteal, subclavian, and brachial artery. External carotid artery is relatively high resistant. Also, low resistant also seen in the vital organs, and common carotid artery with 70% of its blood flow going to the internal carotid also has low resistant blood flow. Another term you have is the laminar flow. Blood flow in the most normal arteries is arranged in orderly layering pattern with the highest velocity in the center, and in the periphery we have lower velocity. Yes, this is the normal pattern.
The laminar pattern.
Laminar
Regular.
pattern. Regular, yes. And normally sometimes you have flow reversal at areas of bifurcation. This is normal, not regarded as abnormal flow. And usually the areas of flow reversal surrounded a black border. True color change is outlined in black. So
Can
we
you
will
explain more about this because it's not.
later we will have another photo. After that we have disturbed blood flow. Turbulent and disturbed spectral waveforms are usually but not always indicate of pathological change in the blood flow. Disturbed blood flow is the loss of normal laminar pattern. Characteristic spectral Doppler signs of disturbed blood flow are either increased velocity or spectral broadening, simultaneous forward and reverse flow, fluctuation of the flow velocity with time. Peak systolic velocity increase with increasing severity of the stenosis. We will talk about them in pictures. So this is the
for those who have any little experience on the Doppler. First of all, you have to know the difference between color Doppler, spectral Doppler, and power Doppler.
Power Doppler.
Okay? The color Doppler is this red and blue thing. Okay? It depends on the direction of blood flow. Whether it's toward the probe, usually it is in the red. Away from the probe, it is in the blue. You can change it as you like. Okay? Power Doppler is when the flow is the color pink, orange, something like that, yellowish color. The whole blood flow is in the same color. It is sensitive to the velocity of the blood flow, not the direction of blood flow. Yani away or towards in the same color. It's more if it's faster and less if it is slower. You cannot know the direction of blood flow by power Doppler, but you can know if it is moving or not. It's more sensitive to the flow.
The blood
not
is
the
present or
direction.
no?
Okay? Spectral Doppler. Sorry? You can, but usually it is this range of color between yellow, green, oranges.
Yes, yes.
Usually it's color. We put the color red and blue. Okay? Sometimes we need to use the power Doppler if the flow is slow flow and we need to be sure there is a flow. Then after we do the color Doppler, the red and the blue thing, we shift to the spectral. We have the spectrum, this thing. Because on the spectrum we can measure this velocity of the blood flow. Is it, for example, 20 centimeter per second, 100 centimeter per second? This is helpful to us. We can know the shape of the curve, can help us to know that this is high resistance, low resistance, if there is turbulence, if there is not. All of this we can note from this curve, the spectrum. So spectral Doppler is this thing.
This is the
color
spectrum.
Doppler is the red and the blue thing. The power Doppler is the yellow-orange thing. Okay?
The first sign of abnormal flow or turbulence is the spectral broadening. Is the widening of the spectral waveform that reflects a broader range of flow velocities within the Doppler sample volume. Usually occurs when the size of the Doppler sample is large compared to the size of the vessel. As we said, you should take in the center of the vessel 2/3 of the diameter of the vessel. When the sample volume is placed near the vessel wall, this is the spectral broadening. Here we have it in the systole and the diastole. It's not clear. Another thing we have is the velocity ratio. Widen, yes.
It's not only widen, the space below. This fills up with color.
Color should be clear.
Should be black.
Yes.
This here should be black, just the curve. Okay? When you have it full, it means there are a lot of different ranges of velocities, slow and fast. There's turbulence flow.
This is the normal.
See, like this. Should be like
Should
this.
be clear.
Because you have all the
Yes.
blood flowing with the same velocity at the center of the laminar flow, at the center of the artery. When you have a lot of velocities due to turbulence, you'll have broadening, filling of the thing.
When you have spectral broadening, it's a sign of abnormal flow, disturbed flow. And another thing is velocity ratio. When the Doppler angle cannot be determined due to poor visualization of the blood vessel or the vessel tortuosity, like umbilical artery. In this case, we take velocity ratio. We have these measurements: systolic over diastolic. We have RI restive index, peak systolic velocity minus end diastolic velocity over the peak systolic, and pulsatility index. These are all calculated by the machine.
You have to know these RI and PI at least. What do we mean by RI and what do we mean by PI? RI is the resistive index, which is peak systolic minus end diastolic
Over
the
peak systolic.
While PI, the pulsatility index, is peak systolic minus end diastolic on the temporal mean velocity.
Mean velocity.
What's temporal?
The mean velocity over time.
Over time. It's
Like 4 or 5
calculated
seconds.
by the machine.
Okay. Go to calculate.
Auto calculation by the machine. This is for assessment of the arterial stenosis. Here we have the normal laminar flow. The velocity in the center is high, in the periphery is low. At the area of the stenosis we have maximum velocity. And also post-stenotic area we will have turbulence. This is the color Doppler. The other one was spectral Doppler. We have two colors. Fast flow appear in the red and red also. The other slow flow will appear blue according to the direction of the probe. If the blood going toward the probe, it will be appear red. If we can invert this, we can make this, and if the blood going toward the probe, appear blue. If the blue is on the upper part, we can change this, no problem. Normal laminar flow pattern demonstrates lighter shades in the midstream and darker shade near the vessel wall, as here, reflecting rapid flow from the middle of the vessel and slow flow near the wall. Disturbed flow, such as turbulence, is indicated by the wide range of colors in a scrambled pattern. Power Doppler. This display color flow information obtained from the interrogation of the power of the Doppler signal rather than Doppler frequency shift. It will not depend on the angle of the Doppler angle. It's sensitive for example, for tumor you detect whether there is blood flow or not. No direction, no other finding, only the presence of blood flow. This is we talked about it. Change in the color within the blood vessel on the color Doppler image can be caused by changing the Doppler angle, as we said, should be less than 60. Changing the blood flow velocity, aliasing and artifacts sometimes affect the color Doppler. Some Doppler artifact we have. First of all, is aliasing is a limitation of pulsed Doppler ultrasound that occurs within both spectral and color Doppler. Aliasing happens when the high velocity blood flow and improper velocity scale and baseline settings. Usually the true color change is always surrounded by black border, whereas color shifts related to the aliasing lag this black border. Aliasing occurs when the pulse Doppler sample rate is too low for a given Doppler signal frequency. To avoid this, the PRF, which is on the machine, must be at least twice the frequency of the sound to be detected. The maximum frequency that can be accurately detected without aliasing is called Nyquist limit and is equal to the half of the PRF. Here is we have his aliasing in the center of the building.
Aliasing and
the true color reversal. We have a black border here.
Yeah. If you have the black line on the edge, this is true. This is not an artifact.
Not artifact.
If you have no black line, see the blue and the red together without black line, this is aliasing. This is artifact. Why it happens when you have
these velocities?
The maximum velocity is 28.9 here. 28.9. Okay, if the blood is flowing more than 28.9
in this vessel,
40 for example, what will happen? The machine will display the extra speed in the opposite direction. In the blue. This is aliasing. So the maximum, this 28.9, is called the Nyquist limit. So the Nyquist limit should be half of the pulse repetition frequency, of half of this. Hatta we get rid of aliasing. Okay, if you decrease the scale, you'll have aliasing. Increase the scale, you get rid of the aliasing artifact. هذا على الكلام. On the spectral, what will happen?
Wrap around.
The extra velocity will be displayed in the opposite direction. Okay, because the Nyquist limit is low, the PRF is low. When you increase the PRF on the machine, okay, you just open the scale a little bit, or you can decrease the baseline, just put it lower. This will go up here, and that's it. Correct the artifact.
And here you can also only increase this scale. You make it 40 and this color will disappear. Or by dropping the baseline. Aliasing may be eliminated by proper adjustment of the Doppler scale or baseline setting, or by using lower Doppler transmission frequency, or by increasing Doppler angle. We have another thing is incorrect Doppler gain. When the Doppler gain is set too low, the Doppler information may be lost and blood flow may not be demonstrated. The color Doppler image with too high gain demonstrate colors in non-flow areas. If the gain is too low, slow flow will be missed in the vessel. If the gain is too high, you will see color Doppler outside the out border of the blood vessel. Velocity scale errors. Velocity range changed settings are too high, may obscure low velocity flow, which is lost in the noise and within the filter of the wall. Vessels that are patent but very slow flow may be considered thrombosed if the velocity range is too high. When the velocity scale settings are too low, a lasing occurs. Such a lasing is corrected by adjusting scale and baseline setting. Color flash is any motion of the reflector relative to the tissue can produce this artifact. Tissue vibration artifact. Vibration of the solid tissue may produce color display in perivascular tissue indicating flow where there is none present. Tissue vibration artifact is produced in non-flow areas such as brood, in IV fistula and shunts. You have fluid motion like in a cyst. If there is any fluid, it may produce a color.
These are all artifacts that can be seen in the Doppler exam.
Yes.
You need to have your hand fixed, the tissue fixed, the patient fixed, everything not moving, only the blood is moving.
Only the blood.
So that you get a good color Doppler image.
Any movement will produce
Movement
colors.
of your hand, movement of the patient, movement of the tissue, for any reason, you'll have noise, which is artifacts, because you need everything to be steady.
Steady.
Hatta you can see the moving blood. Okay? Will produce color. If you move your hand, color flash will happen. Everything will light like
Yes.
a flash. Okay? If you have something that makes the tissue vibrate, like a brewing, okay, you will have artifact. If the gain is too low, you will miss blood flow. If the gain is too high, everything will be noisy and everything will take color. So you need everything to be in good settings.
We come to carotid ultrasound. Stroke follows heart disease and cancer. The leading cause of death in the United States. Stroke is caused by emboli from the heart or from the unstable plaques in the carotid vessel, or stenosis of the carotid arteries caused by extensive atherosclerotic plaque. We come to the anatomy, internal carotid artery and external. This is the main important point. The internal carotid artery is usually larger in size, about 6 millimeters, and the external is small. The internal carotid artery no branches. In the external we have branches, usually located posterolateral, and usually it courses anteromedial. Courses posterior to the mastoid, usually external is anterior. Internal carotid artery, as we said, is a low resistance flow. And the external is high resistant. Internal carotid artery for identification, sometimes it's difficult in all patients. You have a temporal tab. You do this maneuver to identify the external carotid artery. You will see in pictures. This is the anatomy. We will shift it because you all know about the anatomy of the carotid artery. We come to the plaque evaluation. In every vessel we do, special for the carotid artery, first thing you measure is the intimal medial thickness. We have 3 layers. We have in the inner part, intima, media, and also adventitia. Media is the hypoechoic line between the two echogenic layers. We measure, it should be less than 1 milli. Here is we have thickening of the intima media. We usually see this in the internal carotid artery or carotid Doppler in general. After measuring the intima media, we come to the plaque. Either the plaque is homogeneous, as in here. Also we have calcified plaque, and sometimes we have very large calcified plaque causing posterior shadowing. This is a measurement for the plaque present inside the internal carotid artery. We come to the normal carotid spectra. As we said, no, internal carotid artery is low resistant. Even during the diastole we have flow. We have the external carotid artery, which is high resistant. Sometimes if you cannot differentiate between the internal, you can do carotid tap in the temporal region. You see this pattern.
You tap with your hand, you can see the change in the
color. So this is the external carotid artery. Especially old patients, sometimes difficult. We have the common carotid artery, because most of the blood going to the internal, the pattern is usually more like internal carotid artery. And the vertebral artery is also low resistant. We have normally spectral broadening on this because the vessel is small. Usually in the vertebral artery we see this pattern, low resistant. Duplex ultrasound is well established in screening for carotid stenosis. Properly performed, duplex ultrasound has sensitivity and specificity exceeding 90% for diagnosis of carotid stenosis. The most common parameters used is peak systolic velocity and diastolic velocity, and also ratio between the internal to common carotid artery. Peak systolic velocity is most accurate parameter for stenosis greater than 50% and less than 90%. At approximately 50% stenosis, spectral broadening of the internal carotid waveform seen, and mild increase in peak systolic velocity. Above 90 to 95 stenosis, the peak systolic velocity usually falls as stenosis approaches occlusion. The ratio is most helpful when the common carotid artery velocities are abnormal. This is the most popular one used worldwide. Normally the peak systolic velocity is below 125 and no plaques. The ratio between the internal and common carotid is less than 2 and end diastolic velocity below 40. In below 50%, the velocity is below 125. Only sometimes we see mild increase in peak systolic velocity. Other parameters are normal. In 50 to 69%, we have the range of peak systolic between 125 to 230, and the ratio is between 2 to 4, and the end diastolic velocity is between 40 to 100. Above 70% on near occlusion, usually above 230 peak systolic, and the ratio is above 4, end diastolic is above 100. Near occlusion is the problem. Sometimes the peak systolic velocity undetectable. Sometimes maybe low, maybe normal, maybe high. So this is variable. Sometimes mistaken. You see the near occlusion you regard it as normal. We'll talk about it later. Total occlusion, the flow is not detected in the internal carotid artery. This is the internal carotid stenosis. This is the normal pattern. We have the clear window here, systolic and diastolic flow. Here is the image is inverted, but if you look at the scale, the velocity is 300, so it is more than 70%, above 230. And we have spectral broadening here. No clear window. The Doppler window is not clear like here. And end diastolic velocity is above 100, so this is more than 70% stenosis. We have Tardas parvus waveform. Is commonly demonstrated on Doppler spectral downstream from a significant arterial stenosis. Any arterial stenosis you have significant, after the stenosis you have this pattern of, it's called Tardas parvus. Tardas refers to delayed or prolonged early systole acceleration. Parvus, another term, refer to the diminished amplitude and rounding of the systolic peak. Usually this pattern we see after severe stenosis.
So when you have a series waveform, you look for stenosis up.
Yes, up.
And if you see it in the popliteal artery, you look for stenosis in the, for example, femoral, common femoral or iliac.
Yes.
Up. That's the thing. It's slowly increasing and slowly decreasing.
No
slowly
uprise.
Increasing and Tardas parvus. Okay?
These are causes of low common carotid artery velocity. Below normal it's between 50 to 100. Low cardiac output, heart failure, cardiomyopathy, effusion, and wide diameter arteries. If bilaterally we have high common carotid artery velocity, either high cardiac output, hypertension, hyperthyroidism, bradycardia, or narrow diameter arteries. Sometimes unilaterally low. We have less than 50, severe proximal stenosis, severe distal stenosis or occlusion, wide diameter or long segment. Also we have unilateral high velocity. In the common carotid artery, we don't have a special chart to detect the degree of the stenosis. We have this velocity ratio, systolic velocity. We have velocity ratio used to estimate percentage stenosis. The velocity at the stenosis is divided by the velocity of the proximal to the stenosis. We come to these parameters. 2 by 1 is 50% stenosis. 3.5 by 1 is 75, and 7 by 1 we take two peak systolic velocities and divide it by.
Before you divide by
this way you take for common carotid artery, you take the degree of stenosis, because sometimes you see the stenosis in the common carotid. We have occlusion suggested when no flow is identified within the vessel with spectral analysis and color flow imaging. On grayscale, the internal carotid diameter may be small or filled with echogenic thrombus. A brief systolic peak followed by a reverse is usually present at the proximal end of the obstruction due to thumping of the blood against the occlusion, called thud flow. This is common carotid occlusion of the internal carotid artery. This is on the color Doppler. We see the externalization of the spectral. We see the externalization of the common carotid artery. Here we have systolic peak and there is no flow, and also you have reversal. This picture is seen in the complete occlusion of the internal carotid artery.
Internal is completely occluded, so there's no flow in the diastolic
No
at
flow.
all. And even in the systolic, you have just go and it hits the occlusion, goes back. Hits the occlusion, goes back.
Yes.
Hits with no flow, it's occluded. So you have this appearance.
This is the common carotid artery, but appear low resistance as external carotid artery because the blood is going to the
External.
to save the vital organ. We have this is the third flow. The blood is coming and hits the occlusion and it will be reversed. It means that there is no flow. This is internalization after a long-term occlusion. The blood from the external carotid artery going to the internal. So we will have internalization of the external carotid artery, the spectrum.
After there's occlusion of the internal
Carotid artery, yes.
the external, long time طبعا, the external carotid artery will develop collaterals to the brain. You'll open multiple collaterals to the brain. The external will act like an internal. It will supply the brain,
The vital.
which is a vital organ. So instead of being high resistance, normally external, راح يصير low resistance. راح يصير مثل internal carotid.
Save the brain.
So there will be internalization of external carotid artery.
Yes. Here is the external carotid artery. As you see, you have the peak systolic and diastolic. Even the diastole you have flow, it will appear as low resistance pattern. Yes. Near occlusion, the distinction between the total occlusion of the internal carotid artery and thecal flow is of critical importance because patients with thecal flow are candidates for carotid endarterectomy and those with total occlusion are not. Despite advanced in carotid ultrasound, 5 to 7% thecal flow is not detected. Usually you should go to the CT or MR angiography to take this 5% because are candidates for endarterectomy. Another thing we have is the subclavian still syndrome, result from innominated subclavian artery occlusion or severe stenosis proximal to the origin of the vertebral artery. In this circumstance, the blood flow from the vertebral artery will be reversed to supply the upper limb.
You know the subclavian still syndrome? When you have the subclavian artery
It's the
occluded at
first-
the origin, the blood will go from the brain through the vertebral artery into the upper limb.
Upper limb reversed.
Instead of going from the subclavian to the brain, it will go in the opposite direction. Okay? If
Reverse.
it's mild, you can exercise the upper limb to make blood more goes. This is steal. It's stealing the blood. The upper limb is stealing the blood from the brain.
In the carotid Doppler study, we have common pitfalls. First of all is angle of insonation. Usually the angle should be less than 60. Spectral analysis with angles of interrogation greater than 60, we will have a large errors in the velocity calculation, so we try to be less than 60. Tortuous and narrow vessels. The laminar flow pattern is usually disturbed as the blood flow through a sharp bend. Reporting higher velocity at the outer bend is in a tortuous vessel may overestimate the degree of stenosis or falsely suggest a stenosis when none is present. At the carotid bulb, as we said previously, we have a little amount of flow reversal usually seen. Calcified plaques is usually making a problem for us. Dense calcification with shadow, it may obscure the area of stenosis. So we use the color Doppler. If you see the homogeneous flow of the blood during around the calcified plaque, so less likely to have significant stenosis. If you see a lasing or areas of multiple colors mixed on the color Doppler, usually there is significant stenosis. You should search for it because it's obscured by the calcified plaque. Sometimes you have unilateral high-grade stenosis may result in elevated flow velocity in the contralateral common carotid and internal carotid. Bilateral stenosis causes physiological flow alternation that may complicate determining which side presents the more significant disease. Tandem lesions, the presence of more than one high-grade stenotic lesion can lead to interpretation errors. A significant intracranial stenotic internal carotid artery lesion causes a reduction in the peak systolic velocity with the absence of diastolic flow in the cervical portion. Alternatively, significant proximal common carotid artery lesion lowers the peak systolic velocity and increases the diastolic flow in either circumstance. A stenosis in the cervical internal carotid artery may be underestimated.
يعني إذا عندك internal carotid artery intracranial فوق, we cannot see that, there is a severe stenosis.
You
شو راح
may
يصير؟
have
راح يصير high resistance. the resistance up. So تقيس الانترنال كارد يطلع high resistance بس هو internal كاروتيد المفروض low resistance. ليش؟ لأنه اكو ليجن انترا كرينيال فوق cannot see. بالعكس if ليجن بالكومن كاروتيد داون ومسوي stenosis شو راح يصير؟ decrease the blood flow يقلل اكثر بعد. Okay? So you'll have a low velocity, you don't know why, because there is stenosis down. يعني تفتح الحنفية الماء يجي قليل، ليش؟ لأنه stenosis من الرئيسي. Okay?
yes. Sometimes there is significant stenosis and the peak systolic velocity may be normal. Mistaking external carotid for internal carotid, as we said, we can do the temporal tap and look for branches of external carotid artery. As we say, internal has no branch in the neck. Near occlusion. The peak systolic velocity and the diastolic velocity may approach normal. This is the problematic for us. Severity of the stenosis can be grossly underestimated if the grayscale and color flow imaging are not performed. Tardas parvus, as we said, if you have significant stenosis after that, you will have this pattern of spectral Dopplers. Systolic upstroke is flattening and the peak at the maximum systolic velocity is rounded. Findings are most pronounced as the waveform is obtained rather distal from stenosis. We have non-atherosclerotic causes of the carotid disease. First of all is the arteritis, carotid dissection, also seen. Fibromuscular dysplasia is another cause for carotid stenosis. Valvular heart disease. We continue, Doctor. We have abdominal vessels, abdominal aorta.
Antegrade flow internal carotid artery. In the common carotid artery occlusion, retrograde flow of external carotid artery will show the reversal flow in the external.
If the common carotid artery is occluded, external راح يجيب blood from the other side and pour it to the internal. يعني إذا common occluded, and external brings the flow, blood, and to the internal. So the flow will be reversed in the external, while in the internal it always be towards the brain. The brain is the most important thing. The body, you should serve the brain. Okay? كله راح يصير lower grade. راح يصير internalization of external. Okay?
We have externalization of the common carotid first, then later we will have internalization of external carotid. Abdominal aorta we will shift this because we all know about the anatomy and the branch. We have abdominal aortic aneurysm, more than 95% of aneurysm of the infrarenal region, and the size 2 to 4 millimeter per year will be increased. According to the rupture, if the size is less than 4, we have 10% chance. 4 to 7 is 25% chance of rate, and 7 to 10, 45, more than 10 is 60%. This is the abdominal aortic aneurysm, large aneurysm seen here. This is the thrombus and the narrowing of the lumen. Here we have rupture aortic aneurysm, hemorrhage, and this is the spine, heterogeneous area seen around the lumen of the aorta. We should suspect that there is rupture. Sometimes you have dissecting aortic aneurysm. This is intimal flap between the true lumen and the false lumen, as seen here in the axial section. Peripheral arterial ultrasound. This is the anatomy of the lower limb vessel. Common iliac external, it will become superficial femoral, tibial and tibioperoneal triangle. It will be peroneal and posterior tibial. We all know about the anatomy. The Doppler waveform each of these arteries, as we said, high resistant, triphasic flow. Normally, in the upper part is 110 centimeter per second, in the lower part is 70. The same parameters for carotid. Second phase is post-ilotic reversal, as you said. Here is.
So as you go more distally, smaller artery, the velocity decreases. So you should decrease your scale as you go further.
Yes. We have minor stenosis here for lower limb artery, less than 50%. Only peak systolic velocity increased, and the ratio is less than 2, as we said in the carotid. In the moderate stenosis, 50 to 75%. We have the ratio of peak systolic velocity more than 2, and you may have monophasic waveform or moderate marked post-stenotic turbulence. Severe stenosis, 75%. Ratio is more than 2.5, with end diastolic velocity in the stenotic zone usually higher than the systolic velocity in the pre-stenotic zone. Post-stenotic waveform, as we said in the carotid, is usually tardas parvus appearance. The same. We have pseudo Aneurysm also of the most commonly in the femoral artery after arterial puncture. This is an echoiglesian. Here we have two in and out flow.
Defect in the wall of the artery. Blood is leaking, but it is contained. Okay, so it's a pseudoaneurysm. Does not have a wall.
Yes.
You see typically this appearance, the yin-yang appearance.
Blood
red
coming and
blue.
out, red and blue.
Okay.
Always mixed. You have AV fistula. This is the common femoral artery.
Go back, please. Just one thing. When you see this appearance in any, especially if fresh, so in القسطرة مثلا 2, 3, 4 days ago, what you do, you identify the neck, you put the probe, you press really hard, press إلى أن شتافك توقع, okay, for like 10-15 minutes. Sometimes it will thrombose and it will be cured. That's it. عالجنا خلاص. Sometimes, not always. But we don't have it in the usual the thrombin, okay? So you just press on the neck very hard, very hard, okay? For like 10-15 minutes, so thrombosis.
And identifying this picture, this is the neck, you have the mixed colors of the blue and red. This is the area of AV fistula. We have AV fistula. Common femoral artery, as we said, usually it's high resistance. So if there is communication with the vein, you will have low velocity pattern. Here in the diastole we have common femoral vein show abnormal pulsatility. This is abnormal for a vein. And great saphenous vein also there is abnormal pulsatility. So there is from AV fistula, communication between artery and the vein. We have the venous ultrasound also. Normal venous ultrasound examination. The most important thing is compression. This is the vein, this is the artery. We compress and the vein is completely compressed and sonolucent thin wall. This is normal. This is normal with cardiac, with respiratory phase T. We have monophasic. This is during cardiac cycle. And here we do augmentation by compressing the lower limb. You will have a peak. This is indicating that the proximal and distal the venous flow is competent. No obstruction. It's patent. Yes. DVT, deep venous thrombosis, risk factors you all know about, immobilization, age, pregnancy, and oral contraceptive, etc. The important of making the diagnosis is that 90% of pulmonary emboli arise from the lower extremity. Untreated DVT results from pulmonary embolism in 50% of the cases. Acute DVT is the most accurate criterion, is the loss of compressibility of the vein, most important one. In chronic DVT, you will have thick wall and irregularity. Sometimes you see the thrombus. Here is we have acute thrombus, no compression. If we compress the vein, no compression. Here in the color Doppler, you have no flow in the vein. This is longitudinal section. You can see, sometimes you can see the thrombus inside. Here you check by spectrum, you have loss of the cardiac phase T, monophasic here. And also in the longitudinal section artery, there is flow. In the vein, there is no flow. It's easy.
Flow in the artery,
no flow in the vein. Yes. This is the chronic thrombus. You will have echogenic thrombus inside the vessel, and also you will have irregularity and thick wall. This is indicating the chronic DVT. And after you will have recanalization. The last topic is the chronic venous insufficiency. It's common, affect 20% of American adults. Usually, most common cause is post-DVT. After an attack of DVT, you will have incompetent valves, and the blood flow usually going from the superficial to the deep. If any blood flow going from the deep to the superficial, there is incompetent valves. Yes. Here we use 3 techniques for incompetent valve, and the patient, as we said here, should be in standing position. It's better to be done. We have augmentation technique, manually squeezing the leg to increase the venous return towards the heart. With the release of the pressure, blood drops back toward the feet. Transient of less than 0.5 second reflex from deep to superficial is normal. You measure it here on the scale. If less than 0.5 seconds, it's normal. More than this, it's abnormal, suggesting chronic venous insufficiency. We use Valsalva maneuver, increase intra-abdominal pressure and forces venous blood back toward the feet. Retrograde flow indicate chronic venous insufficiency. Third technique is direct retrograde compression by squeezing the leg just above the side of the Doppler examination, which forces blood toward the feet if the chronic venous insufficiency is present. Here is normally we see the venous flow. The patient is doing Valsalva and there is no flow.
If the ملخص, to worry about all of the techniques. The valve should be competent.
Competent.
Well, competent valve, blood flow in one direction, just towards the heart. Any reversal of a flow, معناها الvalve incompetent. ولا قصد. Reversal less than half a second, acceptable. More than 1 second, insufficient. The valve is incompetent. Okay, ممكن تخلي المريض يعصر valve maneuver, ممكن you compress the calf, ممكن you compress the abdomen, whatever you like. المهم ما يصير reversal أكثر من نص ثانية, half a second. If reversal more like this is incompetent valve. ولا قصد. تمام؟
Squeezing above the level of examination.
يعني if you are examining the calf, you squeeze the thigh to see the reversal.
The blood is returning back to the foot, and if up competent valve, it will go to the superficial system. Upper extremity Doppler ultrasound for venous can be done the same way as the lower limb. Also, the same finding: venous thrombus, you have echogenic thrombus and not compressed. The same finding as lower limb. It's not common. The last topic is thoracic outlet syndrome. Most common presentation of patient thoracic outlet syndrome is pain due to compression of the brachial plexus. Sometimes we have venous and arterial obstruction. Here is the subclavian artery. Subclavian vein waveform is normal with basic flow while the arm is at the patient side. When you abduct the arm, it will be abrupted. So there is some sort of obstruction on the artery.
The flow should be continuous. Flow when the patient arm by the side, normal. You make abduction, you see flow disappear. Compare with the other side always. And if the other side is normal, flow continuous beside or abduction, then there is a thoracic outlet syndrome.
Sometimes the cause is arterial. Here in the arterial phase, normally during abduction there is flow. Here we have the high resistant flow. With abduction, no flow, so it's suggesting that the vessel is obstructed. Thank you.
Thank you very much. Very good.
Thank you.
Coverage of a big topic in a relatively short amount of time. Any questions?